Hi, my name is Stephen Sanders. I'm one of the instructors for Great Lakes Seminars. I instruct and teach the hip course. And in this particular video, I want to review what's called the Sacral Shimmy. Now, this is a variation of a sacral technique that is certainly not a substitute for many of the other techniques I've learned through the sacral iliac course itself. But every once in a while, I get a patient who can't lie on their stomach, or it's just a positional issue. In experiencing that, I've created this little variation of a technique to allow me to do a sacral correction in sitting, and in a way to just basically take the four main directions or the common dysfunctions of a right on right, a right on left, a left on right, a left on left, and put them all into one technique. So I have that in the course, and I instruct a patient how to do that themselves. In this video, however, if that's not working, then I have to up the game a little bit. So let's say in flexion or slouching, spinal flexion, we'll keep it simple. I'm going to basically go to the sacral base and assess Tony's sacrum. And in flexion, I might see that he's more posterior on the right in flexion. In extension, it's pretty symmetrical. So I might have him try a self-correction technique, and if that doesn't work, then I'm going to have to get a little bit more involved. So I find that in flexion, the right side is going posterior. So if I just think about handlebars on my bicycle, if the right handlebar is closer to me, my wheel's turning to the right. That's how I turn to the right. So his sacrum is rotating to the right with a slouch or spinal flexion. If that's the case, I'm going to treat it in that position. In extension, it looks symmetrical, so why it's happy there. It's working well into extension, but in flexion, something's not symmetrical. So I'm just going to take that bone in the direction I want it to go. I'm going to use spinal lockouts through rotation to the left to spiral down, engage that sacrum, and just turn it like I'm correcting the handlebars on a bicycle. From below, I don't really concern myself in this particular situation with the inferior lateral angle and get into the specifics, because I'm going to utilize his piriformis muscles with a leg swing left to right, and that's going to create one of the femurs is going to internally rotate as the other one externally rotates. We know that the piriformis at below 90 degrees is an external rotator, and above 90 degrees it's an internal rotator, but at 90 degrees it's the gray area. So the great thing here is if we swing back and forth, we're just wiggling that lower part of the sacrum through the piriformis shimmy effect, and that's going to wiggle at home, and we're taking that upper part of the sacral base, which is engaged with the spine, and we're taking it the direction it's having trouble going all at the same time. So much like a spinal correction, I'm going to palpate that sacral base so I can find, the PSISs of the pelvis, and I just come slightly medial and superior by about 1 centimeter, and that's right around where the sacral base is. So I'm going to get some fingers there to monitor this, or thumb this way, this way, this way, all fine. Tony's going to cross his hands so his hands are on opposite shoulders, and that just gives me a little hold. So I come from the shoulder, slide down, and I grab the point of the elbow here, and I can just kind of use my wrist to guide Tony to where I want him to go. So from here, I'm monitoring the sacrum. We're going to roll down through flexion until we engage a little hinge into the sacrum. So I feel that rolling down, and right about there I feel that engage the sacrum. I'm going to shift him a little bit over towards me and side bend a little bit. And again, I'm trying to stiffen out the spine. Now I'm going to rotate through. The lumbar spine has, give or take, 10 to 15 degrees of collective rotation. The thoracic spine, about 30 degrees of collective rotation. So by about a 45 degree on a healthy individual, I should be locked out. So I know there's biomechanics here, the side bending and rotation in same or opposite directions, but in this case we're locking through the bones, and once we lock them, they become one. So in this case, we're kind of locking through the spine and the sacrum, and now we're taking those handlebars to the left where they're having trouble going. I've got that engaged. I can feel that torque into where my fingers are. Now Tony's going to give me a little effort, like a 1% effort, twisting back to the right against my hold to activate some of those musculatures into the spine. At the same time as he does that, he's going to swing his feet left to right in the same direction, just mid-range, not a hard effort, nice and smooth, 2 and 3. And I can feel that wiggling back and forth under my fingers. 5 and stop. Now we're just going to take up the slack a little bit more. Round 2, he twists to the right, swings the feet. And 5 repetitions or so. Take about 6 to 8 6 to 10 seconds, and stop. And that round 3, twist back to the right against my hold, and swing the feet again. And relax, and if I want, we can do a little stretch to the left, together. Sometimes I get a click, sometimes I don't, that's not important. But now we can go back and recheck and see, in flexion, spinal flexion, or slouch, does that line up, and that looks better to me. Not hard to instruct. A side of a bed's a great place to do this. You don't need a firm surface because we don't necessarily want to encourage locking out the SI joint, but that shimmy with the piriformis muscles going back and forth, I can substitute my hand and try to do this on my own, and there's methods of self-treatment, and I always encourage that for my patients. If I can give them that gift of self-treatment, that's a great gift. So in the course, we cover that in more detail. But I just wanted to review that guided version because sometimes you get a stubborn one and you might need to go 3 directions into that barrier to get that to unlock. But a seated version allows me then to go up and check the spine without having to reposition the patient. Saves me several minutes depending on the mobility of the patient when I get into that clinic, and you know how time is of the essence nowadays. So I hope that helps, and I hope you give that a try and it rewards you like it did myself. Thanks for your time. Good luck.